cataract surgery, which I did not realize until the next day. This is a case history of a female who was 64 years old who had undergone cataract surgery with IQ-IOL implantation. On the day of the surgery, I was very happy with what I had done on that day, until when I saw her the next day. This is how the cornea looked. I was terribly shocked. The patient had severe corneal folds, stromal edema. The anterior segment apparently appeared normal behind the cornea, but I could not see very well. And slit lamp examination also did not reveal too much of information. What could have caused this much of endothelium injury? I could not figure it out. And therefore, when we examined this patient on the anterior segment OCT, we found a huge stromal edema, a very thick corneal stroma edema. It was almost thrice the thickness of the normal cornea, and this was a very huge Descemet's detachment. We called this as a bullous detachment because the ends were intact. Curious to find out what went wrong during the surgery, which apparently appeared normal, we reviewed the recorded file. The common causes of Descemet's detachment were an traumatic entry with an keratome, or aberrant movements with the cystotome when performing rhexis, or the patient moving too much. This patient was cooperative, not that it was just my fault, but this patient was cooperative. But still, I could not find out a reason for her uncooperativeness being a contribute to Descemet's detachment. I was also looking at inadvertent movements by the spatula or the chopper or the phacoprobe moving in and out of the eye, which could have caused a Descemet's detachment, but everything seemed fine. I could not find out a cause. Even the IOL implantation did not cause a drag of the endothelium, which could have caused a Descemet's detachment. Everything seemed fine. Until the end of the procedure. Now, this took us at least many minds together and many days together to find out what exactly had caused this Descemet's detachment. Kindly watch here. Now, these corneas have been hydrated, the incisions have been hydrated well, and now I would like to draw your attention to this wave. See here, there was a wave which went right across. I did not realize that I had injected fluid inadvertently. And again, I'm showing this again, and I re-injected again to make sure that the cornea was hydrated, the incision was hydrated well. I did not realize that I had inadvertently injected fluid, and I kept concentrating on the hydration. Having realized that this was the cause, there was a Descemet's detachment, the next step was how to manage this. Of the available options, the air injection, gas, C3F8 or SF6, high viscosity cohesive viscoelastics, transcorneal suturing, do nothing, or do a keratoplasty. We had these options for us. We decided to inject C3F8 perfluoropropane because over air and SF6 because of its longer retention time into the anterior chamber, and the tamponade which it would give for a week should be sufficient to fix the Descemet's on the stroma. We therefore decided to use C3F8. The next question was, with such a huge stromal edema and Descemet's detachment, which should be the optimum site to inject C3F8 from? We therefore took horizontal scans from superior to inferior and found that the area of least detachment was superior. This was the Descemet folds, but which were least in the superior and maximum in the inferior quadrant. Again, we took vertical scans from nasal to temporal, and we saw that there were more folds nasally, which kept reducing as we went more temporal. Therefore, we decided a schematic was derived manually, and we found out that this was the area of least detachment, the temporal, the superior, and the supratemporal. We therefore decided to use the temporal approach and made a limbal paracentesis first, using a 1 mm keratome. We then allowed some aqueous to egress out and then injected pre-constituted C3F8 into the anterior chamber. The gas bubble was filled up enough so as to tamponade the Descemet's to the stroma. The patient was then asked to lay down supine, and the eye was monitored for intraocular pressure control. However, after a week, I was a little upset with what I saw. The cornea edema was still present, the folds were also present, the stromal folds, and the Descemet had been attached in the central part, but there were still folds persistent in the periphery. We therefore decided, and there was an air bubble which was seen in the anterior chamber, but which was small enough and could not provide adequate tamponade. We therefore decided to re-inject C3F8. However, again after the C3F8 injection, the folds were still persistent. And we therefore subtly, with a very soft voice and kind of, it was a hard time to talk to the patient that she would have to undergo a surgical intervention, but I did gather courage and tell her that. However, the patient got scared with another intervention and was lost to follow up. I was a little relieved that she decided not to come back. 8 months later, the patient again came back to our clinic, and I was pleasantly surprised to see that her cornea was almost clear in the center. She had some fixed Descemet folds in the periphery, some folds also on the central cornea, but which were away from the pupillary axis. But her vision had improved to 6/12 with best correction, and she wasn't complaining. That was the best part, that she wasn't complaining, to my relief. When we looked into the literature as to what could have been the cause for this reattachment after 8 months, we found that endothelial hyperplasia, migration and redistribution have been noticed in some cases of Descemet's detachment, and was probably the cause of reversal of the corneal edema. Because this patient had a good specular had a good endothelium count, perhaps there was a reattachment. From then on, I have been very careful in performing stromal hydration. We make sure that we use a 27 gauge cannula. We introduce the cannula midway between the external and the internal entry, and we also want to introduce the cannula at a more superficial plane, close to the anterior stroma, rather than being more posterior. Again, notice that the orientation of the cannula was kept as much as parallel to the limbus as possible. Every time we try to inject only fluid so that it covers about 1.5 to 2 millimeters around the incision and not beyond it. A few months later, after I started being more careful with my stromal hydration, I caused another complication, a localized Descemet's detachment. In this case, there was a long tunnel and the visibility of the incision was poor. I was trying to inject viscoelastic and I did not realize that I was unable to see the internal entry, and therefore I inadvertently injected it. I did not realize the gravity of the situation until I saw this patient again on the next day. This was the localized Descemet's folds. In such a case, what I learned then on was to avoid using the main end, avoid using that incision which does not have clearly visible, and instead use another port to inject or for entry or exit of instruments, or for also injecting intracameral fluids. A few months later, I again did another stromal a complication with stromal hydration, and in this case, kindly note here that you will see a fluid wave going right across, this wave. Now, this time I did realize that I caused a Descemet's detachment when doing stromal hydration. So immediately the next thing was to use a high viscosity cohesive viscoelastic ProVisc. I'm injecting it right in the corner and kept injecting it towards the center to tamponade it sufficiently so that the Descemet's could be attached to the stroma. The patient was then monitored for the intraocular pressure control. On the next day, the cornea seemed normal, the Descemet's seemed attached, and everything was fine. We sent the patient back home. However, that patient returned back after a month with a severe Descemet's fold, severe corneal edema again. Again, a schematic was derived, and the superior, the temporal, and the supratemporal quadrants were identified as areas of least detachment. Now, this time we took a different approach. This time we did a conjunctival peritomy first, and then entered the anterior chamber 1.5 millimeter posterior to the limbus. This would help us to make a long track. Again, it would also keep the detached area of the Descemet's away from the injecting cystotome. This was to cause least or minimize the damage to the Descemet's detachment, and also make a decent valve so that the air bubble would not leak out, so that the gas bubble would not leak out. The patient was then monitored for intraocular pressure control, and this was a happy situation later on, where the Descemet's has remained attached till this follow-up. We do expect to see her in a month's time again, but right now the patient hasn't contacted us again. So we keep our fingers crossed she would be fine. Thus, the take-home message is Descemet's detachment is a difficult task to handle. It can happen and is a common complication. Please perform stromal hydration with as much of caution as possible, and do suspect Descemet's detachment in case of unexplained corneal edema. In case of a Descemet's detachment, it is important to act early for Descemet's reattachment. Thank you so much for your kind attention.
Take your lights up.